Usually when we talk about a medical diagnosis, there's this expectation of precision. Like it feels kind of like engineering to me.
Right, like it's a very mechanical process.
Yeah,
Yeah.
exactly. You break your arm, the x-ray shows that like jagged white line and the cover just points at it and says, "There it is. It's a mechanical failure." You fix the axle, you tighten the bolts, and the car drives again.
I mean, it's comforting to view the body that way.
Yeah.
We naturally gravitate toward binary problems, like it's broken or it's not broken. It gives us a really highly visible, easily categorized target to just attack.
But the deeper you get into pediatric musculoskeletal alterations, which is what we are looking at today, the faster that whole illusion just shatters. We're doing a deep dive into an incredibly detailed set of clinical materials today,
Yeah.
focusing entirely on how children's bones and muscles break, bend, and heal.
And, the hidden plot twist of this entire field, the thing that completely reframes how you look at a child in a cast, is that fixing the broken bone is actually, well, it's the easy part. The real danger, the overarching villain in all these clinical materials, is the treatment itself.
Immobility.
Exactly. Immobility. When you force a child to stop moving in order to, heal a localized fracture, you inadvertently trigger this devastating systemic cascade across their entire body.
It's wild to think about.
It is. You aren't just putting a bone in a cast. You are basically declaring war on their respiratory system, their gastrointestinal tract, their kidneys, their cardiovascular network, and this is a big one, their psychological development.
So if the broken bone is like a single pothole, we've just successfully shut down the entire interstate highway to fix it.
That's a great way to put it.
And now we have to watch the gridlock build up on every single side street, just watching the supply chains fail, hoping the whole city doesn't completely collapse before the asphalt dries.
Yeah, and that's the tightrope walk. Every intervention we talk about today carries a heavy physiological cost.
So we're going to trace that gridlock today for you. From the sheer physics of how kids take a fall, to the medieval-looking mechanics of traction, to the cascading organ failure of being bedridden, and finally to those genetic curveballs that twist the skeleton from day one.
It's a profound balancing act for the pediatric practitioner. You're trying to manage the cure without letting the side effects of that cure permanently damage the child.
Well, before we can even look at that systemic shutdown, I feel like we have to look at the inciting incident. Like, what is putting these kids in the hospital bed in the first place?
Right. The trauma itself.
Yeah, and when you look at the trauma data in the source, it is overwhelmingly a product of just, well, the pediatric lifestyle. Young children are at a drastically increased risk simply because of the combination of high mobility and what the clinical text so politely terms inadequate motor and cognitive skills.
Which is a very clinical way of saying.
Toddlers are crazy.
Basically, yeah. I mean, they're top-heavy, they love to run at absolute maximum velocity, and their brains just haven't mastered the concept of deceleration. Or hazard avoidance, really.
They're just going full speed into the coffee table.
Right. Their center of gravity is higher than an adult's, their heads are disproportionately large, and they're constantly exploring a world built for people 3 times their size. So,
Yeah.
I mean, they are going to fall.
They're essentially little crash test dummies. But while accidental falls are the statistical norm, the source makes a very serious point here. Practitioners are trained to view every single fracture with a highly critical eye.
Yes, this is a crucial part of the notes.
The material actually mandates that medical staff must evaluate for child abuse when assessing any traumatic fracture. It's referred to clinically as non-accidental trauma.
And this is a heavy, yet entirely non-negotiable reality of pediatric care. A child cannot always advocate for themselves. Sometimes they're pre-verbal or, sometimes they're just terrified.
So the medical team can't just look at the x-ray in a vacuum.
Exactly. They have to play forensic investigator.
Yeah.
They must constantly ask themselves, does the mechanism of injury, like the physical story the caregivers are telling, actually match the biomechanical reality of the broken bone?
Give me an example of how that mismatch presents itself in the ER. Like, what does that look like?
Okay, let's say a parent brings in an 8-month-old infant. The parent claims the baby was on a low sofa, maybe like a foot off the carpet, and just rolled off onto the floor.
Sounds pretty standard.
Right. But then you pull up the imaging, and the infant has a complex spiral fracture of the femur.
The thigh bone.
Yeah, the femur is the thickest, strongest bone in the human body. To spiral fracture it, you need significant torsion, like a violent twisting force applied to the limb.
Oh, wow.
Yeah, so the physics of a 1-foot roll onto a carpet simply do not generate the torque required to snap a femur like that. The story and the physics are fundamentally incompatible.
So the practitioner has to maintain that differential diagnosis of non-accidental trauma. Because if they just cast the leg and send the child home, they are sending them right back into a dangerous environment.
Exactly. The medical team is often the absolute only line of defense a vulnerable child has. Identifying those physical inconsistencies is just as vital as setting the bone itself.
That's incredibly heavy. But assuming we were dealing with a standard accidental playground fall, the mechanics of how a pediatric bone breaks are actually fascinatingly different from an adult's.
Oh, entirely different. We aren't just miniature adults.
Right. The sources categorize these injuries into complete and incomplete fractures. A complete fracture is like easy to visualize. You step on a dry twig in the woods and it snaps cleanly in two. But kids frequently get incomplete fractures.
Because the architecture of a child's skeleton is unique. Their bones are highly porous and they're much more pliable. Plus, they have a significantly thicker periosteum.
The periosteum, that's the sleeve, right? So
Yes, the dense vascular layer of connective tissue that tightly envelops the bone. It acts almost like a shock absorber and a structural sleeve.
Yeah.
Because of this extra pliability and that thick sleeve, pediatric bones don't always snap cleanly when subjected to force.
the visual that comes to mind is a live green branch still attached to a tree. If you grab a green branch and try to snap it over your knee, it fights back. It doesn't break cleanly.
Right, it splinters.
Yeah, it splinters and frays on the tension side while the compression side just like bends and warps.
That is the perfect biological equivalent. And it's exactly why the medical field classifies that specific injury as a green stick fracture. One side of the cortical bone breaks, while the other side merely bends.
But the pliability of kids' bones leads to other weird deformations too, like bends and buckles. And I gotta ask, a buckle fracture sounds bizarre. How does a bone buckle?
So imagine taking an empty cardboard paper towel tube and smashing it straight down on a table.
Okay.
The cardboard doesn't tear in half, right?
Right.
It compresses, it wrinkles, and it kind of bulges outward at the point of impact.
Oh, I see.
So when a child falls forward and catches themselves on an outstretched hand, the impact drives straight up the radius bone in the forearm. The porous pediatric bone compresses upon itself, creating a raised bulge or a buckle at the fracture site without actually separating into two pieces.
That makes total sense. But obviously, they can also sustain catastrophic breaks. The notes mention comminuted fractures, which is where the bone is shattered into multiple distinct fragments.
Like dropping a glass vase.
Yeah. And we mentioned spiral fractures caused by that intense twisting, shearing force. But regardless of whether a child sustains a simple green stick or a complex comminuted fracture, there is a specific anatomical location that instantly raises the blood pressure of every pediatric orthopedic surgeon in the room.
Oh, absolutely. The epiphyseal plate.
Yes. There is a case study provided in the materials that perfectly illustrates why this is so terrifying. We have a hypothetical patient named Kristen. She's 10 years old. She fell out of a tree and sustained a fracture specifically at the epiphyseal plate of her right fibula.
A classic but very dangerous injury.
Right. The clinical assessment question in the source asks what the most critical consideration is when counseling her parents. And the ultimate red flag is the warning that long-term bone growth can be fundamentally altered by this specific break.
Because to grasp the gravity of Kristen's situation, you really have to understand the biology of how children actually grow. We tend to think of bones as like inert scaffolding that just magically gets bigger.
Like blowing up a balloon.
Right, but they don't grow from the middle outward. The epiphyseal plate, known colloquially as the growth plate, is this highly active zone of dividing cartilage cells located near the ends of long bones.
So the growth is entirely localized. It's like a tiny biological factory situated at the top and bottom of the bone, constantly churning out new cartilage that eventually hardens into bone tissue, pushing the ends further apart.
That is exactly how a child gains height. Those active cells, the chondrocytes, they multiply, line up, and ossify. Now imagine a fracture tearing straight through the middle of that delicate factory.
It's like dropping a bomb on an assembly line.
Exactly. If the growth plate is severely crushed, or if the blood supply to it is severed, or even if it heals improperly and forms a rigid bridge of scar tissue right across those dividing cells, that plate can prematurely close.
It just permanently shuts down production.
Yes, the bone simply stops lengthening. So apply that to Kristen. She is 10 years old. If the growth plate in her right fibula prematurely closes, that specific bone is done growing forever.
But her left leg is perfectly healthy.
Right. Her left leg is going to continue churning out new bone tissue until she is roughly 18 years old.
Oh man, so you were looking at 8 years of asymmetrical growth. Her left leg is going to be significantly longer than her right leg.
And the consequences of a leg length discrepancy are massive. It's not just a matter of needing a thicker shoe sole. The human body is a kinetic chain.
Right, everything is connected.
If one leg is shorter, the pelvis tilts to compensate. If the pelvis tilts, the spine has to curve unnaturally just to keep the head level with the horizon.
So she could develop secondary scoliosis from a broken leg.
Yes. Scoliosis, chronic lower back pain, knee joint degradation, and a permanently altered gait. Correcting it later in life might require brutal limb lengthening surgeries where they intentionally break the shorter bone and slowly stretch it apart with metal pins over months.
Which perfectly explains why a fracture at the epiphyseal plate requires such intense, specialized monitoring. You aren't just treating the injury of today, you are trying to preserve the skeleton of a 30-year-old woman.
Precisely. It fundamentally changes the risk profile of what otherwise might look like a simple broken leg.
Okay, so we understand the architecture of these bones and how they break. How do we actually fix them? The clinical text distills the treatment of pediatric fractures down to 2 core phases: reduction and retention.
And the terminology there can be a bit counterintuitive. When we hear reduction, we usually think of making something smaller or lesser.
Right, reducing prices, reducing volume.
But in orthopedics, reducing a fracture simply means repositioning the displaced bone fragments back into their normal anatomical alignment.
You are reducing the displacement. You're bringing the jagged ends back together so the bone factory can bridge the gap.
Exactly.
And once you've achieved that perfect alignment, you move to retention. You have to retain that position against the pull of gravity and, frankly, the child's own movements. This is where we bring in the bodyguards, the splints, the fiberglass casts, the braces.
And in more severe cases, external fixators.
Those always look so intense.
They do. Imagine a metal halo or a rigid carbon fiber cage sitting entirely outside the child's arm or leg. The surgeon actually drills stainless steel pins directly through the skin, through the muscle, and deep into the bone fragments, bolting them to this external cage.
It literally looks like medieval scaffolding.
It holds the bone perfectly rigid from the outside.
So you've reduced the bone, you've applied the cast or the fixator to retain it. The axle is straight, the mechanic's job is done, right? Send the kid home to heal. But this is where the plot twist we talked about at the very beginning rears its head.
The treatment becomes the threat.
Yes. The very act of encasing a traumatized limb in a rigid shell creates a highly dangerous, pressurized environment.
And this brings us to a foundational pillar of orthopedic nursing: the constant, vigilant monitoring of neurovascular status. The materials present a critical mnemonic for this, known as the 5 Ps of ischemia.
Ischemia meaning a restriction in blood supply to the tissues, basically starving them of oxygen. The 5 Ps in the text are pain, pallor, pulselessness, paresthesia, and paralysis.
That's the list.
But I have to stop you on the very first one. Pain. Wait, isn't pain just a completely normal, expected byproduct of having a broken bone? I mean, you just shattered your fibula falling out of a tree. Of course you're in pain. Why is that the leading red flag on a checklist for an emergency?
It's a great question because it's the exact diagnostic trap that catches inexperienced clinicians. Yes, somatic bone pain is expected. That periosteum we talked about earlier is highly innervated. Tearing it hurts immensely.
So how do you tell the difference?
The practitioner have to decipher the flavor of the pain. The clinical notes make a very vital distinction. Pain that is entirely disproportionate to the injury, pain that is not relieved by standard narcotic analgesics, or pain that the patient describes as a deep, unyielding, burning sensation, is a siren blaring.
So it's not the dull, throbbing ache of a healing fracture. It's something much more sinister.
It is the screaming of peripheral nerves that are suffocating. To understand why this happens inside a cast, we have to look at the anatomy of your muscles.
Okay.
The muscles in your arms and legs aren't just loose meat. They are tightly grouped together into distinct compartments. And each of these compartments is wrapped in a thick, incredibly tough web of fibrous connective tissue called fascia.
Fascia is essentially the casing around a sausage, right? It's designed to hold all the meat, blood vessels, and nerves tightly packed together so the muscle can generate force efficiently.
That is an excellent way to visualize it. Now, here is the biomechanical flaw. Fascia has almost zero elasticity. It does not stretch. Right. So consider a child who just suffered a comminuted fracture of the tibia. The surrounding tissue is massively traumatized. The body's inflammatory response rushes blood and fluid to the area, and the tissue begins to swell.
Or maybe a sharp bone fragment nicked a small artery and it's bleeding internally.
Exactly. So the volume inside the sausage casing is rapidly increasing.
But the fascia won't expand to accommodate it, and the hard fiberglass cast encasing the outside of the leg certainly won't stretch.
So the pressure has absolutely nowhere to go but inward.
It turns back on itself.
Yes. The pressure inside the compartment skyrockets, and it begins physically crushing the structures within. The thin-walled veins are the first to collapse.
Which means blood can flow in through the thicker arteries, but it can't drain out.
Exactly, which accelerates the swelling even faster. Eventually, the internal pressure overcomes arterial pressure, and fresh oxygenated blood flow is choked off entirely.
Tissue ischemia.
And this cascades rapidly into compartment syndrome. If prompt medical intervention is not taken, and that usually means rushing the child back to the OR, so a surgeon can take a scalpel and physically slice open the fascia from knee to ankle just to release the pressure, the tissue inside that compartment will die.
What?
The muscle will undergo necrosis, the nerves will permanently die, the child will lose the limb, not from the broken bone, but from the swelling inside the cast.
That is genuinely terrifying. And it puts the other 4 P's of the mnemonic into horrifying logical context. Pallor means the skin of the foot or hand turns stark pale or even blue because no red blood is reaching it.
Right.
Pulselessness means the nurse physically cannot find a pulse distal to the injury site because the artery is crushed flat. Paresthesia is that abnormal pins and needles tingling or total numbness because the suffocating nerves are short-circuiting.
And paralysis is the late, devastating stage. If the patient physically cannot move their fingers or toes, the motor nerves and muscle fibers have entirely ceased functioning. At that point, the damage is often irreversible.
This transforms the whole concept of a cast from a passive healing shell into an active threat that has to be managed minute by minute.
It does, and the notes detail rigid assessment parameters to prevent this. A safely immobilized limb should look pink and healthy. The nurse checks capillary refill.
That's where you press on the fingernail, right?
Yeah, pressing on the child's fingernail until it turns white, and then counting how long it takes for the pink blood to rush back in. It should be brisk, under 2 seconds.
You want the extremity to feel warm to the touch, proving arterial flow. You want a strong, bounding distal pulse. And crucially, you have to enlist gravity to fight the swelling.
Absolutely. The injured limb must be elevated above the level of the heart so the excess fluid can passively drain back into the central circulation rather than pooling inside that rigid fascia.
The practitioner is constantly asking, is our method of retention becoming the new trauma? But, what happens when a fiberglass cast isn't enough? Because sometimes the child's own body fights the reduction.
Muscle spasms.
Right. If you break a femur, the massive muscles of the thigh go into a state of intense protective spasm. They violently contract, trying to splint the injured area. And the source notes that those spasms are so powerful that they will literally pull the broken bone fragments right past each other, causing them to overlap by inches.
A cast cannot overpower a spasming quadricep. I mean, you can cast it, but the muscle will just pull the bones out of alignment inside the shell. When the internal forces are that strong, the body requires constant mechanical persuasion from the outside.
It needs traction.
Exactly. Traction.
Traction is the application of persistent pulling force to an injured extremity. You're basically setting up a physics experiment on the hospital bed to physically exhaust the child's muscles until they give up and let the bones slide back into alignment.
The clinical texts divide this intervention into 2 main modalities, skin traction and skeletal traction.
Let's start with skin traction.
Skin traction is exactly what it sounds like. The pulling force is applied indirectly to the bone by gripping the skin. The nurse applies adhesive strips, elastic bandages, or foam boots to the child's leg, attaches ropes to those bindings, and runs the ropes over pulleys at the foot of the bed down to hanging metal weights.
So the friction on the skin transfers the pulling force to the underlying muscle and bone.
Right.
The notes mention several variations: Buck's extension, Dunlop, Russell, and Bryant traction. But I want to zero in on Bryant traction because the visual description in the materials is genuinely striking. If you are a parent and you walk into the orthopedic ward and see your child in this setup for the first time, I feel like it would be profoundly jarring without context.
Oh, it looks highly unnatural. It subverts all our expectations of how a patient should rest in a bed.
Let me ground this for you. Imagine a 1-year-old child lying flat on their back on a hospital mattress, but their legs are not resting on the bed. Both their legs are wrapped tightly in bandages and pulled completely straight up into the air, reaching toward the ceiling at a rigid 90-degree angle to their torso.
Right, knees slightly bent.
Yeah. And the ropes attached to their legs are pulling upward with so much counterweight that the child's pelvis and buttocks are actually lifted an inch or two entirely off the mattress, literally hovering in midair.
It is a dramatic arrangement, but it is an exquisitely calculated application of physics. Bryant traction is specifically indicated for very young children, typically under 2 years old or weighing less than 30 pounds, who have sustained a fractured femur or are being treated for developmental dysplasia of the hip.
But why hover the hips off the bed? Why not just pull the legs horizontally like normal?
Because you need counter traction. If you just attach a weight to the end of the bed and pull a child's leg horizontally, the child's entire body will just slide down to the foot of the bed. You lose the tension entirely.
Oh, of course.
By pulling straight up, the weight of the child's own body pulling downward toward the mattress provides the exact, constant counter traction needed to fatigue those thigh muscles and perfectly align the femur.
It is brilliant, but the nursing care required for a child suspended in this manner is intense. And it gets even more complex if skin traction isn't strong enough and they have to escalate to skeletal traction.
That's where the mechanical advantage goes up, but so do the risks.
Yeah, that's where the surgeon literally drills a metal Steinmann pin or a Kirschner wire straight through the child's bone, say, the distal end of the femur, and attaches the ropes and weights directly to the exposed metal jutting out of the skin.
The pulling force is vastly superior, but the infection risk skyrockets.
Yeah.
You now have an open metal highway leading directly from the non-sterile hospital room air straight into the center of the child's bone marrow.
To manage this immense responsibility, the clinical notes provide the gold standard mnemonic for traction care. It's simply the word TRACTION. I want to walk through this letter by letter because it reveals just how microscopic the monitoring has to be.
Let's do it. T stands for temperature. The practitioner must constantly monitor for systemic signs of infection, particularly osteomyelitis at those skeletal pin insertion sites. A sudden spike in fever is an emergency, not just a common cold.
Right. And R is for ropes hang freely. This goes back to the physics experiment. If a well-meaning parent pushes a chair against the hanging weights, or if the weights settle onto the floor, or even if the rope gets tangled on the bed frame, the pulling force instantly drops to 0.
And the moment that weight is relieved, those massive thigh muscles will instantly spasm again, violently overlapping the healing bone fragments and destroying days of progress. The weights must always be suspended in free space. Gravity must remain uninterrupted.
US stands for alignment. The nurse has to be a geometric perfectionist here. If the child wiggles and twists their torso so they are lying diagonally across the mattress, the angle of the pull is completely altered. The bone will heal crookedly.
So you have to constantly reposition the child, sometimes even using soft restraints to keep a squirming toddler perfectly parallel with the ropes.
C is the circulation check. We're bringing the 5 Ps of ischemia back into play. With Bryant traction, where the legs are pulled straight up, gravity is fighting arterial blood flow from the heart all the way up to the toes. You have to be hypervigilant for pallor or pulselessness.
T reminds the nurse of the type and location of the fracture, individualizing the care plan. But I is where we start to see the systemic issues creeping in. I stands for increased fluid intake. And we're going to explore exactly why pushing fluids is life or death in just a moment.
A is for overhead trapeze. This is a sturdy triangular bar hanging from the frame above the child's chest. It allows older children to grab on and lift their upper body to help the nurse adjust the bedpan or check their back for bed sores.
It provides a tiny, crucial sliver of physical autonomy in a situation where they are otherwise entirely helpless.
And finally, N is no weights on bed or floor, driving home the mechanical absolute of the R point. The entire system fails if the weights touch a surface.
So we have reduced the bone. We have retained it by trapping the child in a heavy cast. We're suspending them in a complex web of traction ropes for 6 to 8 weeks. We have solved the localized mechanical problem.
But this brings us to the core theme, the true terror of this deep dive. When you stop a human body from moving, you are not just hitting pause. You are declaring war on nearly every organ system.
The human physiology evolved under the constant demand of movement. Muscular contraction is the invisible engine driving circulation, digestion, and respiration. When you enforce immobility, that engine stalls.
Let's look at the gridlock on the side streets.
We can start with the respiratory system. When a child is playing and running, they're constantly taking deep, expansive breaths. Gravity pulls their diaphragm down, maximizing lung volume.
Right.
But when a child is lying supine flat on their back in a traction bed for 2 months, the heavy abdominal organs shift upward, physically pressing against the diaphragm, preventing it from fully descending.
The physical space for the lungs to expand is severely decreased. Their breathing becomes shallow. They aren't taking those deep, ventilating breaths.
And your lungs are constantly producing mucus and secretions to trap dust and pathogens. Normally, deep breathing and coughing expel this fluid, but with shallow, restricted breathing, those secretions aren't cleared. They begin to pool and stagnate in the lower lobes of the lungs.
Like a stagnant pond in the summer.
Exactly. And that warm, stagnant fluid becomes the perfect, nutrient-rich breeding ground for opportunistic bacteria. The bacteria multiply, the lung tissue becomes inflamed, and the alveoli fill with pus.
Pneumonia.
Yes.
The child came in with a broken femur, and they are suddenly drowning in their own lung fluid. That is the domino effect. And the clinical intervention here isn't a drug, it's physics. The notes dictate the use of Inspire techniques and an inspirometer.
An incentive spirometer. It's a simple, brilliant piece of low-tech engineering. It's a clear plastic cylinder with a mouthpiece and a little piston or ball inside.
You hand it to the kid and basically make it a game. You tell them to take a massive deep breath in through the tube to see how high they can float the ball.
And by forcing them to create that deep, negative vacuum pressure, you physically pop open the collapsing alveolar sacs at the base of the lungs. You expand the tissue, loosen the pooled secretions, and allow them to cough it out. It's a mechanical solution to prevent a lethal biological infection.
From the lungs, let's track this gridlock down to the genitourinary system, the kidneys and the bladder. This is the physiological connection that genuinely blew my mind when I read the notes.
It's a wild sequence of events. Again, we have to look at the loss of gravity. The ureters, the tubes connecting the kidneys to the bladder, rely partially on gravity to drain urine continuously.
Right.
When a patient is horizontal for weeks, that drainage slows. The bladder doesn't empty as efficiently. You get urinary stasis, where urine just sits in the bladder, which rapidly leads to cystitis, a painful bladder infection. But the real danger originates in the skeleton itself.
We tend to think of the skeleton as dead rock, but it's alive. It's highly dynamic. I remember reading about Wolff's Law in physiology. Bone adapts to the physical load under which it is placed. If a tennis player serves with their right arm for 10 years, the bones in their right arm will actually become thicker and denser to handle the stress.
Exactly. The mechanical stress of walking, running, and jumping signals the body to deposit calcium and build strong bone trabeculae. But what happens when that load drops to absolute zero? The child is suspended in traction. There is zero weight-bearing force on their skeleton.
The body is incredibly efficient. It realizes it's expending energy maintaining dense bone mass that it isn't currently using, so it initiates a demolition project.
It activates cells called osteoclasts.
Yeah.
You can think of osteoclasts as the body's natural bone demolition crew. They attach to the bone matrix and secrete acid and enzymes, rapidly breaking down the bone tissue and releasing its stored calcium directly into the bloodstream.
The skeleton literally begins dissolving itself into the blood because it thinks it doesn't need to be strong anymore.
Which causes the blood calcium levels to spike dangerously high. Now, where does all your blood go to be filtered?
The kidneys. The blood rushes into the kidneys, carrying this massive, unexpected load of dissolved bone calcium. And the kidneys are already sluggish because the child is lying flat.
The concentration of calcium in the slow-moving urine becomes too dense. It precipitates out of the solution. The calcium atoms start bonding together, crystallizing inside the delicate tubules of the kidney.
Boom! Renal calculi, kidney stones. Formed entirely because a broken leg caused the skeleton to demineralize into the bloodstream. That is a terrifying microscopic chain reaction.
It is the ultimate illustration of systemic connection. A broken femur causes a kidney stone. This is why the IRI and RTACTION mnemonic stands for increased fluid intake. The nursing intervention is to constantly push water and clear fluids to artificially increase the flow rate through the kidneys, flushing out that excess calcium before it has time to crystallize into a jagged stone.
Let's follow that fluid down into the gastrointestinal tract, the gut. The clinical notes casually mention that inactivity decreases appetite and causes constipation, but the physiological reality is much darker than just needing a laxative.
Oh, absolutely. The human digestive system is highly reliant on physical ambulation. The act of walking, twisting, and bending literally massages the intestines. It stimulates peristalsis, the involuntary wave-like muscle contractions that propel food and waste through the digestive tract.
So when you immobilize a child, peristalsis slows to a crawl.
Right, and the large intestine's primary job is to absorb water out of the waste. So if the stool is just sitting there, moving at a fraction of its normal speed, the colon just keeps sucking water out of it, becomes hard, dry, and impacted. But the notes warn of a condition far worse than basic constipation, a paralytic ileus.
A paralytic ileus.
If the immobility goes on too long, compounded by the heavy narcotic pain medications often used for fractures, you hit a terrifying wall. The motor neurons in the bowel essentially give up. The smooth muscle goes to sleep. The gut literally becomes paralyzed.
All movement stopped.
Yes, the digestive contents halt completely. Gas and fluid continue to be secreted into the stomach and intestines above the paralysis, causing massive, incredibly painful abdominal distension. If not resolved, it can lead to bowel obstruction, vomiting of fecal matter, or a catastrophic bowel rupture causing fatal sepsis.
To combat this, the text suggests encouraging a diet high in fiber and pushing those fluids again to keep the stool soft. But it also explicitly mentions utilizing attractive food preparation.
Which sounds so simple, but it's vital.
Think about the psychology here. The kid is in pain, they are trapped in a bed, they are depressed, and their gut is shutting down. They have absolutely no appetite. The nurse and the parents basically have to become culinary artists, creating visually fun, enticing meals just to coax the child to take a few bites, hoping that introducing food will kickstart the sluggish peristalsis.
You are fighting a physiological shutdown with a smiley-faced pancake. It requires immense creativity and patience.
Next on the gridlock list is the cardiovascular system. The danger here is deep vein thrombosis, or DVT, blood clots.
We have established that immobility shuts down the muscle engine. Well, your heart is strong enough to pump blood down into your legs, but pumping it back up against gravity is a monumental task. Yeah, exactly. The body relies on the calf muscle pump. Every time you take a step, your thick calf muscles contract, physically squeezing the deep veins in your legs, forcing the venous blood upward through one-way valves back to your chest. It's like a secondary heart.
But in a traction bed, that secondary heart is turned off. The blood perfusion plummets. The venous blood begins to pool and stagnate in the deep veins of the lower extremities.
And human blood is designed to coagulate when it stops moving. That stagnant pool of blood in the calf begins to clot. It forms a solid mass, a thrombus. The leg swells, turning red and agonizingly painful. But the localized pain isn't the real threat.
The threat is if the clot breaks loose.
Exactly. If a piece of that thrombus snaps off, it becomes an embolus. It travels up the inferior vena cava, passes straight through the right side of the heart, and is pumped directly into the delicate vascular network of the lungs, where it immediately wedges into a pulmonary artery.
A pulmonary embolism. It instantly cuts off blood flow to a section of the lung. The patient gasps for air, their oxygen saturation plummets, and it can cause sudden cardiac arrest.
To prevent this, the interventions are entirely focused on artificial pumping. If the child can't squeeze their own calves, we have to do it for them. The notes prescribe anti-embolic stockings, tight, graded compression socks that physically narrow the veins to increase blood velocity.
Or they use those sequential compression devices, the SCDs.
Right. The plastic sleeves wrapped around the calves that systematically inflate with air and deflate, mechanically mimicking the squeezing action of walking.
We also have to address the superficial damage, the integumentary and muscular systems, the skin and the meat.
We mentioned the osteoclasts dissolving the bone. Concurrently, the muscles that aren't firing begin to rapidly waste away. This is severe muscle atrophy. A child can lose a staggering percentage of their muscle mass in just a few weeks of bed rest.
And while the muscle shrinks, the skin dies. Pressure ulcers, commonly known as bed sores. When a patient lies in one rigid position, the heavy, bony prominences of their body, the heels, the sacrum, the shoulder blades, crush the skin against the firm mattress.
It's a localized compartment syndrome. The pressure exceeds capillary filling pressure. The tiny blood vessels in the skin are squashed flat. Oxygen is cut off, and within hours, the skin tissue begins to die and slough off, creating a deep, open wound that can expose the bone underneath and invite massive infection.
The interventions here are relentless. The nurse must perform diligent skincare, rolling the patient if their traction setup allows it, and inspecting every inch of the body for the faintest red spots that indicate early capillary damage. They must aggressively encourage active range of motion exercises in the arms and the unaffected leg to maintain at least some cardiovascular demand and muscle tone.
And finally, we arrive at the invisible casualty of immobility, psychological and developmental trauma.
A 10-year-old stuck in a hospital bed for 2 months isn't just losing muscle mass and bone density, they are losing their childhood. They're yanked out of school, isolated from their peer group, stripped of their privacy, and robbed of their autonomy.
This aspect cannot be overstated in pediatric care. A child's psychological development, their sense of identity, is fundamentally rooted in physical exploration, chaotic play, and peer socialization. Immobility severs all those developmental tethers. They regress. They become depressed, angry, or entirely withdrawn.
The clinical notes actually treat this with the same urgency as a pulmonary embolism. They mandate specific psychosocial interventions. The care team must request a hospital tutor to maintain cognitive engagement and prevent them from falling behind academically. They actively facilitate written or digital contact with classmates to preserve their social identity.
The practitioner has to treat the mind to save the body, because a severely depressed child will refuse to eat, accelerating the paralytic ileus. They will refuse to use the inspirometer, inviting pneumonia. The mind and the body are hopelessly entangled.
It really paints a picture of orthopedic nursing as a war fought on half a dozen fronts simultaneously. You are fighting the shattered bone, the drowning lungs, the crystallizing kidneys, the paralyzed gut, the clotting blood, the dying skin, and the isolated mind, all at once.
It requires a phenomenal synthesis of holistic medical knowledge.
Let's shift our focus a bit. Up until now, we've talked about massive bone trauma and total immobility. But I want to look at the stealthy injuries, the soft tissue damage, and the invisible invaders. The clinical note spends significant time on soft tissue trauma, ligaments, tendons, muscles. I want to start with the classic first aid protocol that everyone learns in middle school health class, RICE. If you sprain your ankle playing soccer, you do RICE. Rest, ice, compression, and elevation. It has been the gold standard for decades for treating sprains, strains, contusions, and joint dislocations. The goal is straightforward. Minimize the immediate inflammatory swelling, reduce the localized pain by numbing the nerve endings with ice, and protect the traumatized tissue from further immediate damage.
But the clinical notes introduce a revised, extended version of this acronym. They push the ICES method. ICES, ice, compression, elevation, and support. They dropped rest and added support. Why the change in philosophy? What does support bring to the table that rest doesn't?
It represents a shift from passive observation to active mechanical shielding. Think about what a severe sprain actually is. It is the stretching or violent micro-tearing of the ligaments that hold a joint together. Ligaments are the biological duct tape of your skeleton. If you tear the ligaments in your ankle, that joint is now fundamentally unstable.
It's wobbly. Exactly. Now, rest simply implies lying on the couch and not walking on it. But rest is passive. Even if a child is lying in bed, they toss and turn in their sleep, they jerk their leg. If that unsupported, unstable ankle flops sideways during the night, they can easily rip those healing ligament fibers wide open again.
I see. So adding structural support, like wrapping it firmly in an ACE bandage, applying a rigid walking boot, or using a specialized splint, mechanically shields the joint. It essentially acts as an artificial ligament, locking the joint in a neutral anatomical position so that unintended movements don't destroy the microcellular repair process happening inside.
Precisely. It is a much more robust approach to ensuring the joint heals tightly, preventing chronic instability later in life.
Now let's talk about the stealth invader, osteomyelitis. The notes define this simply as a bacterial infection of the bone, but I want to dig into why this is so much more terrifying than a standard bacterial infection on your skin or in your throat.
Osteomyelitis is a completely different beast because of the architecture of the battlefield. If you get a cut on your arm that gets infected, your body's immune system recognizes the threat. It dilates the local blood vessels and floods the area with white blood cells, macrophages, and antibodies. The soft tissue is highly vascularized. It's a superhighway for the immune system to reach the fight.
But bone is different.
Bone is dense, calcified matrix. While bones do have blood vessels, the microcapillary networks deep inside the cortical bone and the marrow are incredibly complex and relatively sparse compared to a muscle.
Which means your white blood cells simply cannot deploy in overwhelming numbers to the site of the infection. The bacteria are hiding out in a biological fortress.
And that fortress protects them not just from the immune system, but from our medications. Standard oral antibiotics simply cannot achieve high enough concentrations deep inside the bone matrix to eradicate a stubborn staph infection. If osteomyelitis takes hold, it begins dissolving the bone from the inside out, creating pockets of dead bone called sequestrum.
To penetrate that fortress, the clinical notes dictate that the child often requires extremely aggressive, long-term intravenous or IV antibiotic therapy, sometimes lasting 4 to 6 weeks. But here's the phrase in the notes that stopped me in my tracks. It states that the core nursing goal is administration of antibiotics without iatrogenic injury. I had to look up that word, iatrogenic. It means illness or severe harm caused by the medical examination or treatment itself.
It encapsulates the ultimate agonizing paradox of advanced medicine, trying to ensure the cure doesn't permanently maim the patient.
What does an iatrogenic injury look like in the context of treating a bone infection? How do the antibiotics become the villain?
To breach the bone fortress, we use heavy-duty, highly toxic IV antibiotics, drugs like vancomycin or powerful aminoglycosides. These are the nuclear options of the pharmacy. But they are notoriously harsh on the human body. Specifically, they can be highly nephrotoxic, meaning they physically destroy the filtering structures of the kidneys, and ototoxic.
Otoxic meaning the ear, they damage the auditory system.
Yes. They can permanently damage the fragile hair cells in the inner ear or the auditory nerve itself.
Oh, wow. So if you aren't perfectly careful, you successfully cure the bacterial infection in the child's femur, but you send them home permanently deaf or needing a kidney transplant. That is the iatrogenic injury they are fighting.
Exactly. It's an incredibly dangerous tightrope walk. The nurse cannot just hang the IV bag and walk away. They have to act as a pharmacologist. They constantly draw blood to monitor the peak and trough levels of the antibiotic, ensuring the drug concentration is high enough to kill the bacteria, but stays just below the threshold that causes permanent organ damage. They monitor daily kidney function labs. Furthermore, pumping high-concentration, acidic drugs into a child's small, delicate veins for a month can chemically burn the blood vessel, causing severe phlebitis. The nurse has to fiercely protect and rotate the IV access sites to prevent the vein from collapsing.
It is staggering how complex it becomes. We've spent this entire time talking about trauma bones breaking, ligaments tearing, bacteria invading from the outside. I want to transition to the curveballs of development. What happens when the skeleton doesn't break but simply grows incorrectly from the very beginning? The medical notes highlight 2 major structural conditions: developmental dysplasia of the hip, or DDH, and scoliosis. Let's start with the hip. What is physically wrong in DDH?
The hip is a classic ball and socket joint. The rounded top of the femur, the femoral head, is supposed to seat deeply and securely inside a cup-like depression in the pelvis called the acetabulum. In developmental dysplasia of the hip, that socket doesn't form correctly. It might be too shallow, shaped like a saucer instead of deep cup. As a result, the femoral head slips around loosely, or it might be completely functionally dislocated outside the socket.
And this is a congenital issue, something pediatricians are hunting for the absolute second a child is born. The notes detail the detective work involved in an infant assessment because, obviously, a 4-week-old baby isn't walking, and they can't point to their hip and say, "This feels unstable." The practitioner has to rely on visual and tactile clues.
The external signs are subtle, relying on the physics of a dislocated bone. Nurses lay the infant on their stomach and look closely at the gluteal folds, the creases of skin, where the buttocks meet the back of the thighs. If one hip is dislocated, the femur shifts upward, altering the tension on the skin and the underlying fat pads. This creates asymmetrical, unequal folds of skin on one side compared to the other.
They also test for limited abduction. Abduction means moving the limb away from the midline of the body. If the ball is resting outside the socket, the surrounding muscles tighten, and the practitioner won't be able to spread that leg outward as far as the healthy leg. But the absolute gold standard diagnostic tool mentioned in the text is the Ortolani sign.
The Ortolani maneuver is a physical test that requires a highly trained touch. The practitioner lays the infant on their back, flexes their knees to 90 degrees, and gently but firmly abducts the hips outward while applying upward pressure with their fingers on the greater trochanter of the femur.
And what are they feeling for? The notes describe it as a positive clicking sound.
Clicking is the commonly used term, but it's much more visceral than that. It is a profound, palpable clunk. If the hip is dysplastic and resting outside the shallow socket, that gentle upward and outward motion will physically force the femoral head to slide back up over the cartilaginous rim of the pelvis and drop down into the acetabulum. The practitioner literally feels the bone pop back into joint under the fingers.
That is wild. Now, what happens if it's subtle and they miss it? The child goes home, grows into a toddler, and starts trying to walk.
The mechanical failure becomes obvious. The notes state that an older child with missed DDH will present with a highly distinct limp, a waddling gait, and unequal leg lengths. Because the dislocated femur is riding freely higher up on the side of the pelvis, that leg physically functions as if it's shorter.
So early intervention is critical to avoid lifelong disability. For a young infant, the primary treatment discussed is a splinting device called a Pavlik harness.
The Pavlik harness looks like a complex web of soft canvas straps and Velcro. It wraps around the infant's chest, shoulders, and legs, specifically holding their hips and knees bent and splayed wide outward. It looks somewhat like a little frog position.
And how does holding a baby like a frog fix a shallow pelvic socket?
It's pure biological engineering, relying on the cellular growth we discussed earlier. The harness isn't forcefully pushing the bone. It merely holds the femoral head perfectly centered deep inside the acetabulum 24 hours a day. Because an infant's skeleton is growing so rapidly, by keeping the ball perfectly centered, the body's natural cartilage generation is stimulated to slowly grow and deepen the socket entirely around the ball, permanently capturing it.
It directs the cellular growth. But the notes heavily emphasize that the success of this device relies entirely on intense parent education. The parents can't just take it off when the baby is fussy.
The nurse must teach the parents how to check the straps, how to aggressively manage skin care to prevent raw friction wounds under the canvas, and how to properly slide a diaper under the straps without altering the precise 90-degree hip alignment. If the harness fails due to non-compliance, or if the dysplasia is too severe, the child faces surgical reduction.
And surgery leads straight to the spica cast.
Yes. A spica cast is a massive, rigid fiberglass shell that starts at the child's mid-chest, wraps around their abdomen and pelvis, and extends all the way down one or both legs to the ankle, locking them rigidly in that abducted frog position. There is merely a small window cut out in the groin area for toileting.
Talk about the ultimate immobility threat. You put an infant in a spica cast for 3 months and we are right back in the domino effect. The risk of pneumonia, the skin breakdown on their lower back, the constipation from an immobilized gut. The parents essentially have to run a mini ICU in their living room.
Exactly. The mechanical cure reignites the systemic risks.
Let's move from the hips up to the spine. Scoliosis. The notes define this as a lateral or sideways curvature of the spine. We aren't talking about poor posture or a hunchback. The spine physically twists and curves into a C or an S shape when viewed from behind, and the epidemiology points like a laser beam at a very specific demographic. It primarily targets adolescent females between the ages of 10 and 15.
It strikes precisely during the most aggressive period of adolescent skeletal growth spurts. It is often painless in the early stages, meaning it is usually discovered during routine school nurse screenings or by a parent noticing an asymmetry.
The physical signs are a fascinating study in biomechanics. Because the spine is twisting, it pulls the entire kinetic chain out of alignment. You see one shoulder noticeably higher than the other, or one hip jutting out. The head might not align centrally over the crease of the buttocks. And the most prominent sign is the apparent rib hump when the child bends forward to touch their toes.
That rib hump is crucial. The spine isn't just bending sideways, the vertebrae are actually rotating on their axis like a corkscrew. Because the ribs are firmly attached to the vertebrae, as the spine twists, it forcibly pushes the ribs on one side of the chest backward, creating a hard, asymmetrical hump under the skin of the back.
If the curve is significant, the conservative management protocol is incredibly intense. We are talking about rigid bracing. The source specifically highlights the Milwaukee brace.
The Milwaukee brace is a heavy-duty, full-torso orthosis. It consists of a molded plastic pelvic girdle that grips the hips, connected to rigid vertical metal bars in the front and back that extend all the way up to a ring around the neck. It uses custom-placed pressure pads attached to the bars to push constantly against the convex side of the spinal curve, attempting to force the spine to grow straighter.
And the prescription is brutal. The child is instructed to wear this rigid, highly visible plastic and metal cage for 23 hours a day. They are granted exactly 1 hour off for showering and skincare. Now imagine the psychosocial reality of this. You are a 13-year-old girl. You are navigating the absolute minefield of middle school, dealing with puberty, trying to figure out your social identity, and you are locked in a medical shell that dictates how you move, sit, and dress for 23 hours a day. The psychological destruction must be staggering.
It is arguably the most difficult aspect of the treatment. This is why the nursing interventions detailed in the notes pivot heavily toward the psychosocial. The practitioner doesn't just check the tightness of the screws, they have to actively manage the adolescent's mental health.
The notes explicitly mandate teaching the patient to wear a seamless t-shirt tightly under the brace to prevent the plastic from causing severe friction ulcers on the skin. But then they suggest active clothing modifications, teaching the teenager how to buy oversized sweaters or structured jackets to camouflage the brace so they don't feel like a walking medical specimen.
The text utilizes a very specific phrase. The nurse must plan with adolescent ways of improving self-concept.
Mhm.
You are treating the teenager's mind as much as their spine. Why? Because in a 13-year-old, compliance is everything. If the brace makes her feel alienated and ugly, she will simply take it off and hide it under her bed the second her parents leave for work. And if she doesn't wear it, the spine will continue to curve unhindered.
And this raises a profound question. Why do we force these kids through such psychological torment just to straighten their backs? Is it merely a cosmetic issue? If a girl has a curved spine but she can still walk, why go to these extremes?
It is far from cosmetic.
Mm-hmm.
And this is where the biomechanics become lethal. If we connect the spine back to the bigger physiological picture, we have to look at the rib cage again.
The ribs attached to the spine encasing the heart and lungs.
Right. If the spinal curve progresses unchecked, say curving 50 or 70 degrees sideways, the rib cage collapses and warps inward along with it. The physical volume inside the thoracic cavity literally shrinks. The lung, situated on the inside of the C-curve, gets relentlessly crushed by the collapsing ribs. It physically cannot expand. If left untreated, severe scoliosis leads directly to restrictive lung disease, chronic pneumonia, and eventually right-sided heart failure and fatal respiratory collapse.
They will literally suffocate as their own skeleton crushes their lungs. So if the brace fails, or if the curve is too severe at the time of diagnosis, the medical team has to escalate to surgical correction. Spinal fusion.
Spinal fusion is one of the most massive, traumatic orthopedic undertakings in medicine. The surgeon makes a massive incision down the length of the back, stripping the powerful muscles away from the spine. They physically grab the twisted vertebrae, applying massive mechanical force to pull the spine back into a straight line, and then lock it in place using heavy titanium rods, hooks, and pedicle screws drilled directly into the bone.
And then they take bone grafts, often harvested from the patient's own pelvis or from a donor, and pack it along the raw vertebrae, tricking the body into healing all those separate spinal bones into one solid, entirely immovable column of bone. The spine will never bend again.
The post-operative care outlined for this procedure is a masterclass in high-stakes monitoring. The notes mandate frequent neurologic assessments.
Which makes terrifying sense. You just took a spinal cord that was perfectly happy living in a curved, relaxed C-shape, and you violently stretched it straight like a rubber band. You have to constantly check if the patient can wiggle their toes, feel a pinprick on their calf, and sense temperature changes to ensure the spinal cord isn't tearing or losing blood supply.
The text also introduces a highly specific mobility protocol. Log rolling for 5 days.
Explain the physics of log rolling, because the visual is intense.
Post-surgery, the patient's spine is an incredibly fragile construct, held together only by freshly drilled screws and soft bone. They absolutely cannot flex their spine, and any rotational twisting motion would instantly rip the titanium screws right out of the vertebrae. So if the patient needs to be turned from their back to their side to prevent those bed sores we talked about, the nurses must roll their entire body as a single, rigid, perfectly straight cylinder, like a log.
The shoulders and the hips must rotate at the exact same millisecond.
Exactly. It requires 2 to 3 nurses coordinating perfectly. One holds the shoulders, one holds the hips, and on the count of 3, they flip the patient in total unison.
The materials also mention keeping the patient NPO nothing by mouth with IV fluids until bowel function returns, because between the massive physical trauma to the nervous system and the heavy IV fentanyl needed for the pain, the paralytic ileus we discussed earlier is almost guaranteed to happen. The gut shuts down completely. Eventually, they are progressively ambulated, often wearing a custom-molded clamshell body jacket to support the fusion as it solidifies over the next 6 months. It is an unimaginably grueling mountain to climb.
It is. Which naturally brings us to our final area of focus, Section 7. Systemic disorders. We are transitioning away from conditions that we can mechanically forcefully fix, like screwing a spine straight or casting a femur, to chronic, progressive genetic conditions. Here, the medical objective fundamentally shifts from cure to management, adaptation, and quality of life.
The notes spend some time on muscular dystrophy. This isn't a bone issue. It's a group of inherited genetic diseases that cause progressive, relentless weakness and necrosis of the muscle fibers themselves. The body stops producing the proteins needed to build healthy muscle. The nursing goals listed in the text are incredibly concise, but when you look closely, they carry massive weight. First, maintaining physical activity.
With muscular dystrophy, the muscle tissue is actively dying. If you place a child with MD on bed rest, the atrophy accelerates at a terrifying rate. The very act of walking, however difficult it becomes, recruits muscle fibers and slows the degeneration. Physical activity isn't just exercise, it is literal life preservation. The longer they stay out of a wheelchair, the better their long-term prognosis.
The second major goal highlighted is managing weight. We talked earlier about how hard it is to move a healthy body when it's encased in a cast. Now imagine a child whose engine in their muscles is losing horsepower every single day. If they consume too many calories and gain excess fat, the physical burden on their weakening legs becomes insurmountable. 10 extra pounds could be the difference between walking to the bathroom and being permanently confined to a power chair.
The clinical notes also heavily emphasize promoting respiratory function, recognizing that the diaphragm and the intercostal muscles that expand the ribs will eventually succumb to the dystrophy as well. And finally, fiercely protecting the child's developmental and psychological growth. You are fighting a losing battle against the biology, so the goal is to grant them as much autonomy, joy, and normalcy as possible for as long as possible.
The final systemic condition the text touches on involves inflammation of the synovium, specifically noting peak onset ages around 2 to 5 years old and again between 9 to 12. This aligns perfectly with juvenile idiopathic arthritis, or JIA. The synovium is the delicate membrane that lines the inside of our joint capsules, producing the lubricating fluid that lets our bones glide smoothly. In these autoimmune conditions, the child's own immune system gets confused. It mistakenly identifies the synovium as a foreign invader and attacks it, causing massive inflammation, heat, swelling, and agonizing joint stiffness.
The goals here are highly targeted, aggressively controlling the pain with NSAIDs or advanced biologic drugs that suppress the immune system, enhancing mobility through daily physical therapy, because inflamed joints will rapidly stiffen and fuse into useless claws if they aren't forced to move, and helping the child identify daily adaptation routines so they can still hold a pencil, open a locker, and participate in school.
But nestled right at the end of the JIA section, there was one extremely specific nursing intervention that completely threw me. The notes instruct the practitioner to conduct periodic eye examinations to detect iridocyclitis.
Wait a minute. We are talking about a child with swollen arthritic knees and wrists. Why on earth are we mandating that they see an ophthalmologist?
This is where we see the truly interconnected, holistic nature of autoimmune disease. The immune system doesn't just attack one localized target, it operates systemically. The exact same faulty immune cells, the antibodies that are attacking the synovial lining of the knee joint, also have an affinity for the delicate vascular tissues inside the eye, specifically the iris and the ciliary body.
Iridocyclitis is inflammation of the eye.
Yes, the immune system engages in friendly fire against the eye.
And the terrifying part is that it's often completely silent, right? Often, yes. In young children with JIA, this ocular inflammation can be entirely asymptomatic. The eye might not even look red. They won't complain of pain or blurry vision until the chronic inflammation causes permanent scarring, cataracts, glaucoma, or irreversible blindness.
The orthopedic nurse cannot put on blinders. They can't just look at the swollen ankle and pat themselves on the back for managing the joint pain. They have to understand the systemic pathophysiology of the disease and fiercely advocate for those regular slit-lamp eye exams to catch the silent inflammation before the child loses their sight.
Exactly, from a swollen ankle to permanent blindness. It proves that nothing in the human body operates in isolation.
Let's step back and take a breath. Looking at the entirety of the clinical material we've unpacked today, it's clear that treating pediatric musculoskeletal issues is the ultimate high-stakes chess match. You have a young child who fractures a bone because they were simply playing too hard. You have to step in and fix that localized mechanical break, put the axle back together. But to achieve that, you have to strap them down. You have to cast them, brace them, or suspend them in traction.
And the exact second you enforce that immobility, you unleash a systemic whole-body threat. You risk destroying their lungs with stagnant fluid and pneumonia. You risk giving them kidney stones as their skeleton dissolves into their blood. You risk paralyzing their digestive tract, clotting their deep veins, killing their skin, and profoundly isolating their developing minds. The practitioner has to constantly pivot, playing defense against the deterioration caused by their own medical treatment.
So, if the cure is currently our biggest threat, where do we go from here?
It raises a deeply provocative question for the future of orthopedic medicine. Given how completely disastrous immobility is for every organ system in a child's body, how much longer will the medical field tolerate it? Casts and traction are essentially ancient technology. We've been tying people to boards for centuries. Will we eventually see a massive paradigm shift? Imagine a future in 10 or 20 years where we develop highly targeted regenerative stem cell therapies that can be injected straight into a fracture, knitting the bone at a cellular level in days instead of months.
Or imagine the evolution of external hardware. What if, instead of a heavy, suffocating fiberglass spica cast, we use a lightweight carbon fiber robotic exoskeleton? The exoskeleton wraps around the broken leg and bears 100% of the physical weight, keeping the bone fragments perfectly isolated and protected in an invisible force field. But the robotic joints articulate perfectly, allowing the child's knee and hip to swing naturally. They could run and play in the yard while the commuted fracture heals inside.
The physiological implications of that are staggering. If you can maintain the mechanics of running without stressing the fracture, you completely eliminate the domino effect. No shallow breathing, so no pneumonia. No venous pooling, so no DVT. The osteoclasts don't dissolve the bone, the gut keeps moving, the muscles don't waste away, and the child goes to school with their friends. The plaster cast and the traction bed would end up in a museum.
Now that is a future of medicine I want to see. You fix the axle while the car is still flying down the highway. Thank you all for joining us on this deep dive into the incredible, fragile, and resilient world of pediatric orthopedics. Keep questioning the physical mechanics of the world around you. Keep an eye on the side streets when the main highway shuts down, and we will catch you on the next one.